Now that we've discussed integrated care, kind of gave you a refresher, let's talk about the new framework for system integration. This was introduced to us last year. So it's called the Comprehensive Health Integration, also known as the CHI. The CHI framework was developed by the group within the Institute of National Council. They put together an expert panel, which included payers, policymakers, American Psychiatry Association, American Psychology Association, SAMHSA, HRSA, CFHA, and many other stakeholders who are involved. So this new CHI framework has been a collaborative effort to promote advancement of integration in more comprehensive way. So I briefly introduced this on our last training, but just to kind of give you a quick refresher again, I discussed why we're doing this new framework. Why is this new framework? Again, there are many reasons to why there are new frameworks to do integrated care, but some of the most prominent reason are these, that many health organizations, we haven't really attempted to implement any of the current models that are out there. There are many studies that have been done in those models. We have good research out there now, but still they're not really been widely used as a standard overall, as an overall standard in the field. Or oftentimes they are implemented as an isolated special or pilot project or service instead of a whole organization transformation. Or they're not able to really sustain or expand beyond initial grant funding. So even if the implementation was successful, they were not able to keep going because the initial grant ran out, therefore the program went away. And so why are we in this situation, right? There are many barriers to the current method of ways that we do integration. Even after decades, we're still not able to commit and really successfully implement integrated care. We started off with the 4-quadrant models. There are the 3 levels of integration, the 6 levels of integration by SAMHSA, which is prominent in the field, and most of the organization use that. And looking at all of the existing models that we have now, we have good research on what is best practice, what makes the collaborative care work, what makes the PCBH model work. But there's good evidence that shows improved clinical outcomes. But in spite of all that, there's still barriers that exist, such as lack of flexibility in implementation, saying that if we don't do all of the components of the model, then you're not really integrated. So maybe there's a need for more incremental, broader approach. It has also been very difficult convincing our payers, either at the government or at managed care. I mean, they like the idea and are willing to pay for, for integrated care, but we're not really able to show value of how integration is improving performance measures. And because of that, we do not have a way to connect our integrated care to the true value, and our payers, they really want to see value. They want to find integrated care programs that actually demonstrate that people get better, but this can fall short if you do not have outcome measures. And because the payers and the policymakers, they really want to see value, and because we're not able to demonstrate those values, we don't get the financial support. So this is where the CHI framework comes in. The CHI framework comes in. It's designed to address those barriers. So this framework, it first emphasizes that bidirectional integration is critical, and that we need to prioritize patient-centered care. So we need to bring integration to where the patient is. Therefore, it covers both and the physical health and behavioral health. So if you're in a behavioral health setting, you need to pay attention to the physical health need of your patient. And if you're in a primary care setting, then you need to pay attention to the behavioral health needs of your patients in order to provide that patient-centered care. So this framework, it's really designed to advance integration for providers, for payers, for policymakers, and population managers. It provides guidance on how to measure progress as you're advancing integration, as you're moving from the earlier stages of integration to more advanced stages of integration. It also allows you to demonstrate value that your organization has produced by advancing your integration. It also provides guidance and recommendations on funding mechanisms that are appropriate for both initiating and sustaining integrated care. So really quickly, these are the main components of this new framework. There are 8 evidence-based domains, which are going to be your care processes. They address both the physical and behavioral health. So it's designed for integrating behavioral health into primary care and primary care into behavioral health. So it gives you the list of exact tasks of what you need to be doing with, of course, some flexibility. Then there are 3 constructs. They are called integration construct. If I were to put that in a simpler way, those can be considered the 3 buckets in which you could be in with your integration process. So you could be at the beginner, intermediate, or advanced bucket as you do the self-assessment on those 8 domains and see which bucket you fall under. And it also has integration metrics, which will allow you to connect your progress to the metrics. And lastly, the integration payment methods. So these are the main components of the framework. So as I was studying this new framework, it's fairly new. I came across some of terminologies that I found used very frequently in this framework. So I figured it would be a good idea to share those common terminologies with you all here. So the integrated services in this framework is defined as physical and behavioral health interventions appropriately coordinated by the treatment team using appropriate interventions for physical health and behavioral health conditions. Integratedness is defined as a degree to which programs are organized to deliver integrated physical and behavioral health preventions and treatment services with consideration to social determinant of health. And lastly, the bi-directional integration. This is when you're integrating physical health into behavioral health setting or behavioral health into the physical health setting. So yeah, I'll pass it over to Alina now so she can talk about the components of the construct.
All right, okay. So now for the constructs, it is a big part of the new CHI framework. So for those of you who joined us last week, we actually showed a snippet of the constructs, and now we're going to be breaking it down, starting with the components. So first things first, as we move through the domains, you might start to notice that the constructs and the domains actually sound very similar. And that is because the names of the constructs are actually driven from the 8 domains based on the measurable processes that have shown direct improvement in health outcomes. And from the domains to describe evidence-based and expert-supported service elements. So really, it is intended to provide some sort of flexibility for the utilization of integrated service delivery based on the organization's missions, resources, incentives, and even capacity. And what that means is that it does not matter how small of an organization you are or how big of a hospital you are with a whole lot of resources. It's kind of like you work with what you have with this new framework. Which leads me to my point, which is that these constructs provide a lot of consistency, again, based on the available resources that you and your organizations have. And the end goal is to ensure that everybody is on the same page, kind of taking similar evidence-based steps towards integratedness with what your organization has to work with. And next, can you go to the next slide, please? Okay, awesome. So these are the 3 constructs that you'll be hearing a lot about moving forward in this presentation. So now keep in mind that the nature of these 3 integration constructs is to measure the progress of where you are in the process of integratedness by monitoring yourself and making improvements where you can at your organization or clinic. And you will need to show how many of the targets that you have achieved under each of these constructs to demonstrate measurable value, which we'll talk about later in the presentation. But to demonstrate measurable value, you do have to, get paid for your efforts from the payers. First one being screening and enhanced referral. Then the second one being care management with consultation. Then the third one is comprehensive, which is also the most advanced one, is comprehensive treatment and population management. And as you can see here, each of the constructs are progressive and advancing to the next one. It actually, to advance the next one, you actually require the implementation of the elements prior constructs. So in other words, it's like you can't skip steps or pick and choose what you want to do. Instead, you have to build on screening and referral. You have to, and then you got to get to care management with consultation. Then you have to get to your comprehensive treatment and population management. And next slide. So now we're gonna go in detail with, talking about each construct and what that stands for. So moving on to integration construct 1, the screening and enhanced referral. So let's start off with what that is. So with this construct, the overall goal is to optimize screening and enhance the screening referral process. So what that means is that instead of saying, hey, it might sound like you have depression, you should go see someone, let me know how that works out for you. You develop an organized process at which you have a MOU or a partnership with a behavioral health services clinic where you have the authority to organize the communication around referrals, following up, tracking, and actively engaging in the sharing information regarding your patient's status, like did they even make it to the appointment, or what are the results of their appointment. And most of the time, this does not require any significant investments in terms of finances. However, this may not always be feasible for all clinics because of the provider shortages for behavioral health entities. And some of them might not be willing to develop a collaboration or partnership to conduct a successful enhanced referral process. So a lot of times what clinics do is hire an internal staff that can take these referrals, but then that ends up being a co-located care. And as we spoke about earlier, that is not integrated behavioral health. And then when it's co-located care, the PCPs and BHPs are not really properly communicating about their patients, nor are they participating in the enhanced referral process of sharing information, results, and even the timelines. So the goal with this construct is that we want to be able to successfully implement this process, even if it means it's co-located care. And once clinics can successfully implement this construct, it can result in improved routine screening of basic physical health or behavioral health conditions, because now the referrals are being tracked, results are being communicated, and high quality treatment is provided. And the purpose of this, as I mentioned earlier, is to collaborate on shared patients to improve access, timelines, and quality of care. And next, please. All right, so now let's talk about what it means to be what it means to have a fully implemented construct 1 and how that impacts the patient's experience. Well, the patients and families will now start to feel like the providers are in different locations, but they are working together as to address both their behavioral health and physical health needs. So instead of being in the middleman that has to say, hey, let's call your behavioral health provider and ask them to fax your results to the PCP, it becomes an automated process for the patients. The doctors are communicating your treatment modalities amongst each other, and they're even bettering their communication. And when you're in the PCP's office, you notice that the PCP is actually interested in identifying your behavioral health condition and the facilitation of the communications or referral to their behavioral health partner and staying on track with communication and following up. And while you're at the behavioral health providers, a similar experience is provided where connections and communication prevention and treatment of the physical health conditions are addressed. Can you go to the next slide? All right, so now that you've successfully, in theory, implemented Construct 1, we are now advancing to Construct 2, which is care management and consultation. So at this point, your organization is strongly committed to integrating your clinic by adapting a stronger screening and tracking processes with on-site care coordination and care management. So in this construct, you have to make some or most infrastructural changes, such as hiring a behavioral health specialist, additional staff that can assist with the registry and on-site care coordination, like someone who can help with making appointments, helping the patients complete their paperwork, educating the patients about their conditions, and even providing them with resources. And now that you've hired a behavioral health specialist to be a part of your team in the same office and have actively integrated them into your routine consultations to provide treatment services for the common and preventable conditions like ADHD, childhood obesity, breast cancer screenings, and really just monitoring that, right? And then the next slide will flip the lenses and see what the patients are experiencing once they're at an organization that actively builds on the elements of Construct 2. And well, now the patients and families start seeing their service team work in a single location, like a BHC being in a PCP's office or a care coordinator within a behavioral health setting. And they will experience that someone from the team establishes a personal relationship with them to help them complete simple tasks like, completing their paperwork and helping them with making appointments and some more. So these individuals will also be interested in improving the patient's overall well-being on a regular basis by walking them through the recommended strategies of lifestyle changes, or even where to find resources. Say the patient needs help in accessing transportation to make it to their screening appointments. So our patients are now experiencing all these additional help than just going to the doctor, getting some pills, and then now going home. And so this type of outreach truly improves patient compliance. I think that's one thing to be mindful about, because they feel like they're being cared for because of the encouragement, additional monitoring, and even the coordination of all the other care and support that they receive. And now we'll move on to Construct 3. So now that you've learned a little bit about implementing Construct 1 and 2, we're moving on to the most advanced construct, which is the comprehensive treatment and population management. So unlike Construct 2, which can only take on a few defined populations in the clinic, Construct 3 is geared towards managing a defined yet larger population of complex needs that can range from HIV, asthma to bipolar disorder and schizophrenia. Typically, organizations that can effectively implement Construct 3 are at this point where your system is fully integrated. And as I mentioned, Construct 3 implies a high level of shared accountability, since it is a larger population that they are providing integrated services to. And when an organization is at this construct, they also have the ability to measure improved overall health outcomes for their populations and take shared risks for risk for costs and outcomes. And as far as the patient experience is concerned, flipping the lenses one more time to talk about the patient's point of view. at this construct, the patients notice a higher level of teamwork in their providers and in their PCP's office or behavioral health office, mostly because they're often in a single location and the experience that their providers are really all in sync. You don't have to repeat what they're saying. Everybody knows what's going on. There's no retelling your story or your diagnosis unless you're completely going to a new provider. But now the patients have more of a regular and proactive approach by their service teams to address the prevention and treatment of a more complex and comprehensive set of co-occurring conditions by also assisting in overall wellness improvement. And most importantly, now the services are so good at their outreach efforts that they actively keep up with the patient. Say a patient missed an appointment and it's been a month since you've heard from them. And because the care team is aware that the patient is a type 2 diabetic, they call them before they run out of their prescription or whenever it's time for the next testing rather than just letting it be. And the way that I like to think about it is that Construct 3 is about providing services beyond the four walls of the clinic or the hospital. It's a continuum of care where they check in on you and make you feel valuable. And compare that with Construct 2, they care and provide support for you in the clinic and send you home with the strategies to and help. However, you're kind of sort of alone once you go home. There's no cause to ask if you tried those strategies or if you even read those articles that they sent you home with and how it's been for you. And Construct 3 takes it to a whole nother level. And so that ends the constructs. And if you have any questions, let me know so far. Otherwise, Regina is going to take over and talk about domains and subdomains.
Okay, so let's talk about the domains and subdomains now. So these are the 8 domains that was put together by the IHCI framework. We are going to try our best to cover most of them here with you, but unfortunately, this framework is so comprehensive that we will not be able to cover all of them. However, by the end of our training, we're also going to provide you all with the toolkit and the framework documents itself, so you have all of the information that you need. So as I mentioned earlier, that this new framework, it does provide flexibility so that both primary care providers and the behavioral health providers can utilize this framework to do their own form of integration. So if you're in a primary care setting, you're integrating behavioral health. If you're doing behavioral health, you're integrating primary care. And as we go through these domains and subdomains today, I want you to also think about your organization and think about which statement in each of the column reflects your current state of integration. So let's look at the very first domain, which is integrated screening, referral to care, and follow-up. So this is one of the large domain. It has 2 subdomain, as you can see here. It's titled as 1.2 and 1.0. These are the subdomains. The first subdomain is called screening and follow-up for co-occurring behavioral health, substance use disorder, physical health conditions, as well as preventive risk factors. So let's look at the traditional practice, and this means where we stand today, our current state. The traditional way of providing care is that patient, they usually come in and they do a self-report, right? They complain about feeling sad or anxious, and so on. And the primary care provider, they might put you on an antidepressant, and they may ask you to go see an external behavioral health specialist and say, why don't you go and check and see who you can see under your insurance, and wish you good luck. And there's really no systematic follow-up. Then on the behavioral health side, the provider may just happen to take your vitals and notice that your blood pressure is a bit high. So they tell you to go see your primary care provider, but there's no partnership there within the providers. So there's no systematic follow-up process. And as we progress into greater integration, and for this first subdomain at the first construct, which is screening and enhanced referral, This is where you begin to incorporate any form of evidence-based approach, which is the systematic screening for the high prevalence of behavioral health or physical health conditions and their risk factors. So, for example, in primary care setting, you would be utilizing PHQ-9 to screen your patients for depression or GAD-7 for anxiety. This means that there's consistency and you're using some form of validated scale or measure. Construct here, you are going to have some sort of formal agreement between the primary care and behavioral health providers, which is also called the Care Compact or an MOU. Alina mentioned this earlier. You have this set up so you're able to facilitate referrals and you're able to share records, follow up on the patient's progress, and so on. This way, you now have a recognized partnership with your primary care or your behavioral health provider, and you're able to facilitate referrals and follow up, which means there are less chance of patients falling through the cracks. And then when we move on to the next concert, which is the care management and consultation, or this column right here, for the first subdomain, in addition to now you're doing systematic screening, you are also providing education on physical health or behavioral health conditions, and you're doing some data collection, and you're tracking how many patients within your patient population they test positive for physical and behavioral health conditions and their risk factors. And you're doing this on an annual basis. And this is how you demonstrate measurement-based care. Then under the second subdomain for the second construct, the care management and consultation construct, you now have the capacity to appoint a behavioral health consultant in a primary care team, or you have a nurse or a care coordinator in a behavioral health setting, and they're able to track and follow up on every referrals to make sure they happen. And this is a step more into, step into more integrated care. And then when we get to the most integrated construct, the third construct, which is called the comprehensive treatment and population management, for the first subdomain, now not only are you doing systemic screening, you have screening tools, you have a system in place like registries to track your patients, you're stratifying, you're identifying to see how many patients have scored high on their PHQ-9s, who are suicidal, you begin to do more analysis of your patient population. And then under the second second subdomain, for this, most comprehensive, for this most integrated construct, you now have a solid electronic integration. You are getting real-time information on your patient because everyone is documenting either on the same platform, or you're getting a real-time feed from other platform because there's a systemic collaborative and consulting partnership between the two providers, along with the automated data sharing, and there's more accountability for patient engagement. So ultimately, you can add value within this domain in terms of better patient outcome and quality improvement and some form of potential incentives that could be recognized for those elements. Now, when we look at the second subdomain, this is a big domain. It can be overwhelming to look at. I'm not going to go through this second domain, but just to kind of give you a summary. So second domain, it's called the evidence-based care for prevention or intervention of common physical health and behavioral health conditions. So to summarize this domain, it focuses on evidence-based care. So all of its subdomain, there are 4 subdomains here. They all discuss how evidence-based guidelines and protocols for preventive screenings, such as depression, suicide risk, opioid risk, how the guidelines and protocols for those are utilized under each construct, how the evidence-based guidelines and protocols are utilized for the treatment of common physical health and behavioral health conditions under each construct, and the use of medication for those common health conditions, and how the evidence-based approach are used to provide trauma-informed care under each of these constructs. I'll pass it over to Lena to talk about domain 3 and 4.
Yeah. Um, so the third domain is ongoing care coordination and care management. And the subdomain is, I can never say this word, but it's their longitudinal clinical monitoring and engagement for addressing prevention and intervention for co-occurring physical health and behavioral health conditions. So looking at the traditional practice column, it seems that there are none or minimal mechanisms for routine coordination and follow-up of patients referred to behavioral health care. And so if we advance to the next construct, which is in alignment with the CHI framework, which is the screening and enhanced referrals construct, we see that the providers for this domain have created a basic tool that tracks follow-up appointments. And there are some minimal help in navigating the patients to their appointments and encouraging them to adhere to taking their medication. Under the next construct, though, the care management and consultation construct, obviously the previous efforts have now progressed and they have a team, a team of members who can provide data analysis to guide their care and their plans, their treatment plans. And this is where the newly hired care coordinator can contact them to provide routine care coordination, and monitor routine follow-ups and even track patient engagement with the clinic. And a great example of this would be that we have Sally, say patient, she comes in with an issue, and under the first construct, they learn that Sally might have depression. And then the doctor recommends, like, hey, maybe you should go see a therapist about that, and they end up there. And then under the screening and enhanced referrals construct, Sally is referred to a doctor that her PCP has a partnership with and helps her make an appointment with them. And her PCP's office is often in communication with the behavioral health services and learn about the medications that Sally needs to be on. And then the care management and consultation, Sally has care coordinators helping her once she's in the clinic to develop, where they try to develop a relationship with her and assist her with her treatment plans and even follow up with her regarding her medications and even her lifestyle coping strategy adherence. And now for the comprehensive treatment, Sally's care goes home with her. So it's very similar to the constructs that we talked about, right? So every few weeks, perhaps, or every once a month, the BHC or a nurse manager or RN will call her and ask her how is she adhering to her treatment plans, and if she likes it or if she doesn't like it. Then they take it back to the doctors and they suggest a new plan on the spot, or even call Sally back after consulting with the PCP. And at this stage is also when they track her responses to the treatments and the outcomes over time. So that's kind of concludes domain 3. And then as far as domain 4 is concerned, that is the self-management support that is adapted to culture, socioeconomic, and life experiences of patients. And the subdomain of self-management is that the use of tools to promote patient activation and recovery. So now this domain is actually one of the most underutilized when it comes to integrated care. In fact, in traditional setting, there is none or minimal patient or family education, healthy behavioral skills, and risk factor screening recommendations. But you move a step up and they provide you with a few resources, perhaps when they're checking you out, or when you're done with the appointment, they give you handouts or web-based resources or articles or some links for you to go visit. And then in the next step up under the care management and consultation construct, is that you move away from the passive form of education into active form of education. And the active form of education can be delivered in person, where you help them navigate through technological applications. Maybe it's like some sort of Instagram or a website that talks fully about diabetes management. Then there are also, I've seen nowadays in PCP's offices, there are digital exam room posters where it's basically a large TV screen on the wall where the providers can teach the patients more about their diseases, how it's affecting them, which makes the conversations and really understanding for the patient about their conditions much, much easier. But ideally, at the end of the visit, you should go home with routine suggestions and strategies on how to take care of yourself. But keep in mind, though, while they do provide you with everything they can, it kind of stops there. The follow-up and the questions on any challenges or concerns will be asked about at your next appointment within the four walls of the clinic, so the care does not leave with you. And in the comprehensive treatment, the far most advanced construct, there is a continuing of recommendations with strategies to improve the patient's own health outcomes by helping the patient increase their knowledge, skills, ability, and willingness to manage their own health by building healthy lifestyle habits. So the provider's office calls them and ensure the patient is still on track with these healthy habits. And if they're not, they will provide or make me recommendations to try. And in this step is also where they remind you to be on top of your screenings and tests for the year. And I think a great example for this is a postpartum, a woman who is in her postpartum after delivery. So we all know that women, after they give birth, they go into postpartum depression due to their hormonal changes. So it is recommended that they take a PHQ-9 screening in each stage of their pregnancy as well as after their pregnancy. And so this is where the provider's office will call them to remind them, like, hey, you gave birth 3 months ago. How are you feeling? You are due for your PHQ-9. How have you been taking care of yourself? Are you doing everything we talked about in our last call? And something along those lines. Basically, the care goes beyond the four walls of the hospital. With that, Sajina, you can take over.
Okay, thanks, Lena. So let's now talk about domain number 5. This is a very busy slide. It can be overwhelming, but I'll walk you through this fairly quickly. So domain 5, it's called a multidisciplinary team, including patients with dedicated time to provide integrated physical health or behavioral health care. So as you can see, there are 3 subdomains under this domain. The first domain is called the care team. So this is all about care team, which, as you know, the more care team you have in your practice who are working together to provide care to the patient, the better communication there's going to be among the team on a regular basis, whether that's, in person or electronically, virtually, the more advanced you're going to be in this subdomain. When we look at subdomain 2, which is the sharing of treatment information, case review, care plans, and feedback, at the first construct, this means that there's routine release and exchange of information through phone, fax between the 2 providers. When you go to the second construct, you go beyond just exchanging information now. The provider, they actually communicate with each other, discuss assessments and treatment plans. That could be either, again, in person, virtually, phone as necessary. And there's a routine notes from providers in EHR for routine reviews. Then when you get to the third construct, there are more scheduled meetings, which can be, again, in person or over the phone, virtually, to discuss complex patient cases. And you now have a capacity of getting all information together in one platform. You have the capacity of doing team-based care, all working together to figure out what is the best path forward for a patient, especially with multi-physical and behavioral health conditions like substance use, anxiety, diabetes. All this could happen in one person. So providing care, it cannot be one person's job, right? You are going to need help, especially if you have patients with multi-condition complexity. You often need everyone's help to figure out what is the best treatment option for those patients. Then when we get to the third subdomain, which is integrated care team training and competency development. This subdomain, it goes into the training aspects of integrated care. So under the traditional practice, right, there is either none to minimal training on integrated care approach and the integration of physical health and behavioral health. Then as we progress through these constructs, all the care teams you have as part of your integrated care team, they all require some level of trainings and trainings according to discipline, depending on your role, because guess what, as you progress through these constructs, there will be higher expectation from your team. Everyone has to have some level of accountability for patient care, and that requires adequate training, competent trainings on integrated care concepts for screening and referral workflows, integrated teamwork with defined roles and responsibilities for each team members, routine integrated team processes like huddles, doing care team meetings, and other ongoing trainings for all staff levels. So that's what Domain 5 is all about, disciplinary team, care team. And then finally, now we're going to discuss Domain 8. And this is the final domain, and it's called financial sustainability. It has two subdomains. One is building process for billing and outcome reporting to support financial sustainability of integration effort. So under traditional practice, there's none to minimal attempt to bill for co-occurring physical health or behavioral health screening, prevention, interventions that takes place on site. The integrated services are usually, they're labeled as a pilot program or special project, separate services that are supported by grants, but there's no process in place for sustainable funding, right? So this ultimately results in program shutdown because you run out of funding. And as we move along these constructs, there's better process in place where you're able to generate fee for the service that you provide, like billing, such as provide billing for physical health or behavioral health screening and treatment services under fee for service, and you're able to track reimbursement for those services. You're building a process to make sure that you have fee captured for the services that are reimbursed using the CPT codes. But just that is not going to be enough to sustain financially. So you need to move on to develop the capacity through outcome reporting to get incentives, and then potentially build value-based payment mechanism with your payers or state providers, so that we're really getting all the financial support that we need after all the investments that we've made. Then on the second subdomain, it is building process for expanding regulatory licensing opportunities. And depending on your state, I'm sure some of you are, all of you here are from different states. Depending on your state, you may actually require additional certification in order to operate under integrated care and to ensure that the services provided by that individual is actually billable and reimbursable. So at the current state, providers, they have very limited understanding of how to provide integrated care or even document for those services provided. So at the traditional practice and under first construct, you are utilizing the existing physical health provider's license to get reimbursed. And when we move further up towards the care management and consultation, that's where you're ensuring that the behavioral health providers that are part of your team are appropriately licensed. They're appropriately credentialed through Medicaid and other payers, so that the clinic, they can get reimbursed not just for the physician's time, but also for that behavioral health provider's time. Then we get to, when we get to the comprehensive treatment and population management, the third construct, here we're making sure your internal processes are in place for all area of the clinic, establishing procedures so that we're consistently able to bill and get reimbursed for all the services that we're providing, and that includes making sure that people within your billing and coding department understand all the codes that can be used in integrated care, and that they're helping to ensure that the electronic health records, your EHRs, has the right workflow to support and promote the code usage that reflects the work that's been done in the clinic. A smooth process so that the providers can provide the care, easily document those care provided into the EHR on the services provided, so that once that information gets to the administrative office, they really do understand the way the care is and how it's being delivered, and so they can optimize code usage, right? It's also about making sure that the clinical licensure requirement for your state or your licensor has clear and consistent protocols, and you're making sure you're ahead of meeting all the requirements that are needed to support integrated care for the population served. So those are all of the domains. Next, we're going to now talk about the metrics for integration under this new framework. Elena, it's you, right?
Can you go to the next slide? Okay. So now let's talk about demonstrating value using the CHI framework, or how are we achieving measurable outcomes? Like, how do I know if the patients are getting better? So we start off by putting a definition to the value, which is a measurable improvement in individual or population health, physical or behavioral health outcomes, or an increased equity or quality in relationship to the expenditure. So for most services and populations, trying to implement integrated services may involve increased costs because you're either improving your system or you are hiring additional staff. But improved health outcomes would outweigh the additional investment, thus demonstrating value. Or you can be a clinic with already high cost and poor outcomes, and this in fact might be reducing your expenses. In other words, if you are putting money into this, are you seeing a positive return, whatever that means to you, whether you're saving money or you have to spend more money so that your patients can be better, or it's all kind of just, lost. But in order to start demonstrating value, you have to start off with picking your population after you measure, after you define what you want to value, right? So you have to identify one or more co-occurring conditions to address through your integrated service delivery. And you cannot start your integrated service delivery with all the conditions in the world. You do have to start off small. You choose one or two, like anxiety and depression, or anxiety and cardiovascular health, or you can identify your condition by looking at your clinic population. Like, what are the majority of your clinic patients dealing with? There are, 50 to 70% having anxiety or struggling with diabetes or cholesterol or cancer risk. It's really up to you and what you and your payer prioritize, right? And then you want to implement those measurable indicators, and that's whether if you are adding an additional screening or lab work, and you need to, make tweaks to your system, from whether it is to improve your staffing, improve your workflow, the resources used, the training provided, and really just what it is that is needed to demonstrate value. And then next slide, please. So let's look at this graph. You can see a triangle, and on each corner of the intersection, there are words like value, integration, and payment. And the biggest takeaway from this is that the more integrated you become in your clinic, the more value, which is progress, improvement, you demonstrate, which leads to connecting your payment to it. Next slide, please. And so how do you choose metrics that demonstrate value? Identifying metrics and targets is a shared process that's between you, the providers, and the payers. So you have to sit down together and decide whether you would like to target behavioral health or breast cancer screenings, about like how many percent of your women population over 40 has kept up with their screenings, or even a colonoscopy for people over 50 who got their screenings done. And so the goal is to choose a balanced set of conditions as you target your goals and your metrics. So as mentioned earlier, you can choose whatever metrics you'd like, depending on what you see is more prevalent in your clinic. But the end goal is that you want to choose something that works for you, so that when you do demonstrate value, you're asking to get paid for that. So that can be, one or more metrics focused on prevention and or treatment of physical health conditions, one or more metrics focusing on prevention and treatment of behavioral health conditions, or one or more metrics that may or may not apply to both. But ideally, you just want to get this. And with that, Sujina will go over some examples on how you can determine metrics in a behavioral health setting or physical health settings for each construct.
Thanks, Alina. So yeah, let's talk about metrics for each construct. So if you think about your organization, if your organization fit under this first construct, then you will need to think about how you're going to demonstrate value under this construct. Screening and enhanced referral, it does have value. There are studies that have been done that shows that if you actually screen and track the referrals, it'll result in value for the patient, for the providers, and for the payers. So here are some of the things to consider. These are some really good examples that National Council put together. So I wanted to share this with you all. So let's look at the behavioral health setting. If you're in the behavioral health setting, you will need to think about the screening rates for heart disease or diabetes for patients with severe mental illness. And what does those screening rates look like? And then demonstrate that you have at least one care compact or an MOU agreement with a primary care provider to provide the physical healthcare aspect for the patient, and show what does the completed referral rate looks like. These are the things that bring value, because by doing this, we know that more people are connected to care. We know that people are getting better. And then in the physical health setting, you need to think about the screening rates for depression, anxiety disorder, substance use disorder. And again, demonstrating that you have at least one care compact or an agreement with a behavioral health provider to appropriately treat your patients with behavioral health needs as you have partnership with them. Then you can look at the percentage of patients who have actually completed the referral. So you will need to have a process in place that enables you to track and see if the patient actually showed up. Was it a no-show? So the construct one is incredibly valuable because you now have data, you have numbers to potentially show to a payer, and you can ask to pay a case rate, so you can afford to hire the dedicated staff like a medical assistant or a care coordinator who can do those screenings and make sure and follow up on those referrals and make sure they're getting where they're supposed to go. Oops. Okay. And then when we think about metrics for the construct 2, the care management and consultation, you can use metrics from construct 1, but here you can go a step beyond. So in behavioral health setting, you can track how many patients with high BMI were offered nutritional counseling, and what's the percentage of that? What is the percentage of patient with opioid use disorder? This actually applies to both behavioral and physical health setting. And what was your retention rate in the 6 months or the 12 months and 18 months? What is the percentage of glucose control for patients with severe mental illness and diabetes? Then in the physical health setting, we are focusing on the percentage of depression symptom reduction, utilizing validated tool like PHQ-9 at 6 months and again at 12 months. How many of those reached remission of depression symptoms in primary care? So this is how we are demonstrating value. Here we're talking about changes, right? Direct clinical interventions. And now we have hardcore metrics that we can demonstrate value that we're bringing because of our integration efforts at this construct 2. So again, this is just an example in your organization. Think about your own patient population and look at some of the potential metrics and come up with your own metrics that suits your patient population. Suits your population best based on how you've designed your integration program. And then lastly, metrics for construct 3. And this is really up there. We have to kind of toughen up a bit, but when you get to the third construct, right? So in this construct, now not only you are doing metrics, but you're also demonstrating reduction in ED utilization, hospitalization, and readmissions. So you're also looking at follow-ups, and these are, again, really up there. And they can also impact the cost of care. So there's going to always be a need to use emergency department and the hospital, but we need to focus on what is preventable, right? And when we're looking at reducing depression and therefore reducing suicidality, that's a possible preventable visit, right? And therefore there's a really focused, this is really focused on the total cost of care, which is what comprehensive treatment and population management should do. So in addition to improving health outcomes and improving patient satisfaction, we're now also focusing on reducing the total cost of care. Because our care, as Alina mentioned earlier, our service should not just happen inside the 4 walls. When we have like engagement outside of our 4 walls, we can have better relationship with our patients. We can help them navigate the most cost-effective and healthiest way to engage them in care. So again, these are just examples. Your organization can pick the metrics that they think will demonstrate value based on what you're doing or the type of integration that you're doing. I know it was a lot of information, but that is all we had put together for our presentation. I'll now pass it over to Victoria so she can close this out.
Hi, everyone. So as always, you can fill out an evaluation survey using this QR code, but I will also be sending the link in a follow-up email. And so you must fill one out in order to get your certificate of attendance, which is what counts towards CEUs. I'll also include the recording of the session, and I'll include a toolkit. Yes, and we can add it to the chat in a moment. But unless anyone has any questions, that's the end of our presentation for today.
Thank you all for joining.
Yeah. Let me just quickly pull up the link and I'll put it in the chat.
We can actually also post these, include these attachments. Thank you, Patty. Thanks for joining. Yeah, so we can definitely also include these toolkits when you do the follow-up emails, Victoria, so that people also have access to that. And National Council also has this available on their website if you want to browse and, find these attachments, these toolkits as well.
Any questions? If not, thank you all so much for joining. We can't share our slides, but I will share the recording of the video so you have access to the slides in that way.
Okay, I think we're good to go. Thank you all so much for joining.
Have a good one, everyone.